This afternoon we're going to address the topic of hematologic abnormalities in cirrhosis. I'm Dr. Rebecca VanDyke, Professor of Medicine and Gastroenterology at the University of Michigan. A typical patient with cirrhosis exhibits poor liver synthetic function. This includes a low albumin, for example, less than 3, and an elevated prothrombin time, such as an INR of 1.9. Also, the patient exhibits thrombocytopenia. Typically, in a more advanced cirrhosis, this might be a platelet count of 57,000, more or less. Leukopenia and anemia may also be present. These observations raise the question of, will this patient have a bleeding tendency, and can invasive procedures be done safely? We'll attempt to address these questions in the talk today. I'd like to start with the cytopenias in cirrhosis. Patients with advanced cirrhosis often exhibit pancytopenia. Thrombocytopenia is usually the first to appear. Raises the question of, does this contribute to bleeding problems? Leukopenia and eventually anemia appear later. So are these of clinical consequence? Let's look at the etiology of the cytopenias. These occur because the cirrhotic liver is badly scarred. That reduces blood flow through the liver. Portal vein pressure then rises, and back pressure into the spleen through the splenic vein causes splenomegaly. This large spleen captures and destroys circulating platelets and cells too rapidly. In addition, the liver is a major source of thrombopoietin, the hormone that stimulates megakaryocytes to make platelets. This next slide illustrates the connections between the liver and the spleen and the portal vein in a normal patient. Blood from the intestines goes up the portal vein, goes through the liver, which is a low-pressure system, and on to the vena cava. Blood from the spleen enters into the portal vein as well. This next slide shows what happens in a cirrhotic liver. Here the liver is scarred. Blood flow through the liver is partially blocked, and blood flows preferentially through systemic collaterals or varices. This high-pressure blood also backs up into the spleen, leading to a big spleen and splenomegaly, and leading to premature destruction of platelets. There are clearly other factors, as shown on this slide, that also can contribute to thrombocytopenia in some patients: marrow disease, drugs, and other issues. But the most prominent ones are the low levels of thrombopoietin and the enlarged spleen. So with this information, we can then ask, does thrombocytopenia cause bleeding? Well, we know that platelets are required for both vascular integrity and to initiate clots when vessels are injured. In terms of vascular integrity, that is compromised only when platelets are lower than 10 to 20,000, and this is lower than most of our typical patients with cirrhosis. So we think vascular integrity is relatively well preserved. Platelets are necessary to initiate clots. However, in cirrhosis, even though the platelet count is low, their ability to initiate clot formation is actually not as impaired as we might think, because cirrhotic patients also have high levels of von Willebrand's factor, and that accentuates platelet function. Thus, in clinical medicine, cirrhotic patients do not generally bleed spontaneously, and clotting is not as impaired as we might otherwise expect. So given this information, do cirrhotic patients benefit from platelet transfusions? There are actually very few good data to address this important question. However, in liver transplant patients with less than 75,000 platelets, invasive procedures can cause bleeding in about 30%. However, these can usually be successfully managed with red blood cell transfusions and post-procedure platelets as needed. Based on these and other expert opinion, there are recommendations that platelet transfusions be used if a patient with liver disease has less than 50,000 platelets for an invasive procedure such as surgery or a liver biopsy, or if there is ongoing hemorrhage such as a variceal bleed. Otherwise, we really would prefer to limit platelet transfusions as there is little benefit from them. The next cytopenia is leukopenia. This may be impressive in patients with advanced cirrhosis, but does not seem to greatly increase the risk of spontaneous infection or decrease the response to antibiotics. Indeed, cirrhotic patients can increase their white blood count if they are infected. For example, a patient with cirrhosis may have a white blood count of 2,500, but can increase it to 6,500 or higher if they're infected. Because of this lower baseline white blood count, however, it's important to compare the white blood count when a patient comes into you and you're suspicious of infection with their prior white count as they may have increased over baseline but still be within the normal range. And an increase over baseline does indicate a possible infection. The third cytopenia is that of anemia. It is frequent in cirrhotic patients, but of course it's multifactorial, as there are other things beyond hypersplenism that can limit the number of red cells. GI blood loss and iron deficiency are two extremely common ones. Hypersplenism clearly plays a role, but in addition there can be a contribution from anemia of chronic disease or alcohol. Anemia should be managed as clinically indicated. Iron should be replaced if iron deficiency is present, and transfused only as clinically necessary. I'd now like to move on to the coagulopathy that is seen in cirrhotic patients. Just as a reminder, liver function includes the production of many blood proteins. These include a whole variety of clotting factors, including those measured by the prothrombin time, factors 2, 5, 7, and 10. Many of these are also vitamin K-dependent factors, 2, 7, 9, and 10, and can be abnormal if a patient is vitamin K deficient. The liver also, however, stimulates and produces a lot of anticoagulant factors. Prominent among these are antithrombin 3 and protein C. The liver also makes factors involved in fibrin formation and in fibrinolysis. Now, the prothrombin time is something that's easily measured clinically, and an elevated prothrombin time has been assumed to reflect problems in blood coagulation in patients with cirrhosis. However, as shown on this slide, blood coagulation may not be as impaired as originally thought. We can't measure the defects in anticoagulation pathways in our patients in any clinically meaningful way, but laboratory studies suggest that defects in the anticoagulation factors may balance out the defects in procoagulation factors. Clinical studies indicate that cirrhotic patients with elevated prothrombin times actually have normal or even an increased risk of venous thromboses, for example. This would indicate that their ability to clot is actually normal or perhaps even a little pronounced. Recent reevaluation suggests that the pro- and anticoagulation factors do remain reasonably balanced in patients with cirrhosis, but the system is not stable, and it's prone to swing either direction rapidly. It's important, therefore, to remember patients with cirrhosis are not auto-anticoagulated, and to remember that infections, sepsis, or renal failure can tip cirrhotic patients into abnormal coagulation states, either into a consumptive coagulopathy or DIC and a bleeding state, or into excess thromboses. The next slide tries to illustrate graphically this concept of rebalanced hemostasis in patients with liver disease. Panel A shows the balance between pro- and anticoagulation factors in healthy individuals. Too many procoagulant factors can cause bleeding. Too many anticoagulation factors can cause thromboses. Many pro- and anticoagulants form a robust system to keep this balance between bleeding and thrombosis. Panel B shows the status in patients with cirrhosis. Here, the pro- and anticoagulants are present and they're balanced, but they are much less robust. There are many fewer of both of them. Therefore, there can be wide swings toward either bleeding or toward thromboses. The next slide compares this concept of a balance to other coagulopathies you may be more familiar with. The left upper corner shows the balanced coagulation state of normal patients. The upper right shows patients with a thrombophilia. The procoagulants are much greater in number, and the balance is toward clotting. The left lower corner shows patients such as those with hemophilia. Their anticoagulants are much out of balance compared to the procoagulants, and they tend to bleed. The right lower corner shows liver disease, which is a balanced but unstable system. So therefore, we have to ask, why is it that cirrhotic patients bleed? Well, although thrombocytopenia and coagulation disorders may potentiate bleeding, in cirrhosis they rarely, if ever, cause spontaneous bleeding, and that's a very important clinical point to remember. So we think that many of the bleeding episodes result from the increased pressure in the portal system and the abnormal vasculature in cirrhosis. These include esophageal varices and portal hypertensive gastropathy. Of course, bleeding can also occur in a cirrhotic patient from other unrelated lesions, such as ulcers, erosive esophagitis, diverticular bleed, hemorrhoids, and the abnormal coagulation state may, of course, potentiate some of this bleeding. The next slide actually shows a picture of a patient with a normal esophagus and on the right-hand side, esophageal varices, just to give you an idea of these huge abnormal blue ropey veins seen coursing up and down the esophagus in a patient with advanced cirrhosis. There's a thin wall there, which if it ruptures can cause considerable bleeding. The next slide shows the endoscopic appearance of severe portal hypertensive gastropathy. These are red spots all over the gastric mucosa. They're due to dilated submucosal veins, and these tend to more ooze blood into the lumen of the stomach, causing low-grade loss and usually more iron deficiency anemia. These are also abnormal vessels that do not have normal vascular integrity. Of course, the coagulation problems in cirrhosis can make them bleed more readily. So overall, what are the clinical implications of coagulation in cirrhosis? First, we should not consider our cirrhotic patients autoanticoagulated. If venous thromboses occur or are a risk, patients should be treated as you would anyone else. They may well need heparin therapy for a deep venous thrombosis, for example. If you see a patient with cirrhosis who has a new change in their prothrombin time, give a short trial of oral vitamin K. They might have simply become vitamin K deficient, and you can correct that abnormality. Finally, remember that our usual clinical coagulation tests and measurements of bleeding time do not accurately predict risk of bleeding with procedures. So what do we do when we have a cirrhotic patient who needs an invasive procedure? Well, there are really no good data to guide our decision about prophylactic infusions of platelets or fresh frozen plasma in patients prior to invasive procedures. Values at which to consider prophylaxis include an INR of greater than 1.5 and/or platelets less than 50,000. So as an example, I've put in the recommendations from the American Association for the Study of Liver Disease liver biopsy guidelines. As you can see, it relies on clinical judgment. But these are values that are recommended by expert opinion, but based on very little actual data. Other clinical implications include the fact that overtransfusion with platelets, fresh frozen plasma, etc. in cirrhotic patients may actually cause more variceal bleeding due to increased intravascular volume. Clearly, patients who are bleeding massively need adequate resuscitation with red cells and volume, and giving them FFP and platelets may help in the acute bleeding state. But overtransfusion can cause progressive problems. Therefore, emphasis is shifted from prophylactic administration of these agents to rescue therapy if bleeding occurs after an invasive procedure or if the patient is experiencing a major hemorrhage. The final slide is another graphic example of an overview of this balance of coagulation. On the upper part of the slide is the normal hemostasis, a broad-based, robust system that doesn't rapidly tilt one way or another toward either pro or anticoagulation. The bottom half of the slide shows the very unstable, poorly balanced state. This is a teeter-totter that can quickly go one way or another, and lists a number of the factors that play roles in either pro or anticoagulation problems in cirrhosis. Thank you.